So I'm going to spend just a few minutes talking about innovation from the vantage point of someone who spends his life in the provider sector. So I know from the introductions you're going to be hearing from folks who span the industry, and will bring very different perspectives. I spend my life working in integrated health systems and hospital systems in North America and Europe. And so that'll be the standpoint that I'm coming from. So I think this is a concept that's familiar to everyone, the spiraling cost of healthcare. No one is being spared. If you look at every system in OECD, the rate is far outstripping the growth of GDP, to the point that over time health expenses are going to consume what many would argue is an unsustainable amount of our gross domestic product, and will threaten our ability to deliver other parts of what we need to. So and Canada, as you see on this page, if you look ahead over the next decade is no exception, going from around 10% to 20, 30, 40, 50% if the current trajectory is unchanged. So clearly, the tension that was introduced a moment ago between the desire to innovate and the requirement of ensuring health system sustainability is an important one. There are many isolated yet very intriguing innovations out there. About a year ago, we embarked on a study of about 30 or 40 of what we felt were some of the most interesting globally. Here's just a sample of a few of them. The first is called Medi-Call Home. So it's a service in Mexico where you pay $5 a month to have telephonic access to physicians. They found that with this program, which is 1/6 the cost of a physician visit, about 2/3 of the visits to the physician office could be averted. Second, an enormous uptake of the program in Mexico. LifeSpring hospitals in India, a set of hospitals in which care is driven by midwives primarily, under oversight of physicians. So the mix between midwives and physicians is far different. They maintain the same level of oversight by physicians in the care. But they also focus deeply on a set of services that's fairly prescribed and predictable. And in doing that, they were able to reduce the cost by 5/6 for the types of newborn deliveries that they concentrate on. A third example, oriented around quality, CMO, Care Management Organization, which is a part of Albert Einstein, an academic medical center, where they've created an integrated care management approach that spans well outside the acute care setting where they're primarily focused. And what they've been able to do in doing that is, and through, again, focus on a set of disease states that drive a lot of morbidity and cost, diabetes, congestive heart failure, asthma, et cetera, is reduce the number of visits to the hospital dramatically, and also reduce the cost of care of these patients. And like I heard about a few minutes ago, in the quality section of the discussion, patients would like nothing more than to not need the health system in the first place, and these kinds of programs can be successful in doing that. There are tons of these. I don't think anyone would be surprised to be aware of the breadth of these. One of the interesting observations that we made, though, as we were exploring was, number one, they tend to be isolated. Number two, some of the most profound innovations tend to be in the developing parts of the world. And as we thought about that and looked at the stories associated with these, what we found was that oftentimes it was because two barriers didn't exist. Existing infrastructure and tried and true approaches to delivering health care, and the kind of regulatory and process constraints to trying a new approach to care delivery. And so as these ideas were pursued in their jurisdictions, they could leapfrog the approach that in Canada or the US or other developed health systems had to be tried first. could instead do it an entirely different way. The Aravind Eye Institute, for example, in India, where they focused completely on, at least for a time, they focused completely on cataract surgery. They developed extremely high throughput. They reduced cost by 3/4, and with world-class outcomes. There's a few secrets of success that we at least have pulled out from this. The first is getting close to the patient and following their established behavior patterns is critical. So if you think about Medi-Cal, for example, as an example, using the cell phone that every person in the world at this point practically is carrying, with CMO, actually bringing a lot of the technology into the patient's home so that adoption is eased and compliance is increased. Second, reinventing the delivery model by using proven technologies disruptively. The cell phone is a great example of this. Both the telephone and video conference, I've seen some great innovations across Canada with some of the remote care that's being delivered through video conference. The third is around confronting professional assumptions and right-skilling the workforce. So in the case of Medi-Cal, or in the case of the Alberta Health System, for example, where they're beginning to consider new multidisciplinary care models for primary care that would help enable nurses to practice closer to their full scope of capabilities, and place physicians as part of a care team that's integrated around the patient. Ideas are being explored that would shift the relative roles over time towards a more optimized approach. Standardizing the operating procedures wherever possible can be of huge benefit. It can eliminate waste. It can improve utilization of assets. Any focused factory that is delivering a type of health service over and over again is over time going to be more efficient. And what we found in a lot of jurisdictions where there are focused outpatient centers doing knee replacement or hip replacement over and over again, higher quality at lower cost with shorter lengths of stay and less patient morbidity. And Aravind Eye Institute in India is again an example. Fifth is to borrow someone else's assets. And this is an interesting one that we picked up in a few different places where the cost of innovation can be high. When you're trying something for the first time, you're spending to learn. You're not spending to drive immediate impact. An example, again in Alberta, where I've spent some time, the Sheldon Schumer Clinic in Calgary, which is it's a very interesting example because I don't think that clinic, which is a polyclinic-like model, like we see a lot in Europe, where it delivers a whole wide range of ambulatory services, diagnostic imaging services, and so on, in a common location. I don't think it would have happened if there hadn't been available shell space from a hospital that was there. So the cost was mitigated to explore that innovation as a result of that. And finally, opening up new revenue streams across sectors, which is more relevant in some jurisdictions than others. But the idea of sharing cost, ensuring that there are additional revenues associated with the innovation, that the physicians are going to be reimbursed for the ventricular assist device implant at the rate that they need to be in order to actually drive implementation at the point of contact with the patient, and so on. So there. As we step back and think about along two axes, the categories of care from you're healthy in the community all the way through long-term conditions in the outpatient setting to acute care to planned post-acute care, and then along the continuum from monitoring, diagnosing, preparing, recovering, and monitoring and managing over time. What we've seen is that there's some clusters of innovation as we step back and look at the 30 or 40 examples that we've seen. The first one I'll talk about is franchising. So this is making a prescribed course of care highly efficient over time. So the example of Vision Spring, for example, which is on this list, where what they've done is this is a company in India where that helps match people with presbyopia with glasses that can help. They've created these business bundles that they hand off to local practitioners who are not medically trained, who can go and help folks on a local basis get matched to the right eyeglasses. So it's a service that would otherwise be very difficult to deliver, but it's franchised through these people who have a local stake, local relationships, local knowledge about what will and won't work in a way that's possible to scale. Technology-enabled networks, I've talked a little bit about telephones, video conference, and the kind of telephonic care that can be delivered through those. Examples are exploding globally of these types of services, whether in remote areas or whether in the home in busy areas. People would prefer not to touch the healthcare system if they don't have to, or to touch the healthcare system in a different way than they have in the past while staying in the comfort of their home. The third is production specialization, which is what it sounds like. It's isolating and narrowing the scope of services to the degree that it can be done with a high degree of replicability, verity, and efficiency. And these three examples are all good ones. And I think they're interesting to a point because they're so isolated, but I think you also see some very interesting examples in health systems like Kaiser Permanente, where there are pathways of care oriented around common disease states, where from the outpatient setting through the acute stay to the post-acute stay, there's a predictable pathway, there are predictable roles that different practitioners will play along it. And finally, integrated care, which is a bit of tying together a lot of what the rest of these into the patient perspective. So delivering care from the perspective of the patient who doesn't see their health as a series of interactions with the health system, but rather something that's more continuous. And we've seen some great innovations at the Veterans Health Administration in the US, Kaiser Permanente, in Valencia, Spain, where there was an enormous investment in electronic medical record infrastructure and localization of healthcare, such that a patient's experience of the system was more integrated. While if you look at the map of the health system across Valencia, Spain, it looks less integrated. So it's taking that from a patient perspective. So there are a number of questions, and I'll leave you with this that I think one has to consider. As I've seen other health systems in other countries grapple with how to bring innovation to the front line around the delivery system, have seen some interesting innovations, but it's often required changes in people's roles, changes in the incentive algorithm, changes in the rules around interface between different stakeholders in the system. And I think some of these questions are the ones that folks will need to grapple with over time in order to capture the innovation and eventually both improve outcomes and start to bend the curve of cost growth.